A sudden, critical arterial blockage often appears to happen entirely without warning, suddenly striking individuals who otherwise appear completely metabolically healthy. Consider a recent clinical case study of a male in his late 40s. He is an ultra-endurance athlete with optimal blood pressure. This dossier shows his 10-year ASCVD score, a standard metric calculating the probability of atherosclerotic cardiovascular disease, sitting at a very low 4.1%. Yet a routine cardiac screening triggered a follow-up angiogram, which revealed severe 75% stenosis, or structural narrowing, in his proximal left anterior descending artery. The blockage was driven by highly volatile, low-attenuation plaque. Current diagnostic protocols rely heavily on measuring low-density lipoprotein cholesterol, or LDL, and apolipoprotein B to assess risk. In this patient, those traditional metrics completely failed to predict the massive plaque accumulation. The underlying driver of this vascular decay is lipoprotein A, or LPA. LPA is a highly atherogenic, genetically determined biomarker that is present in elevated, dangerous concentrations in approximately 20% of the global population. Relying exclusively on traditional LDL-lowering targets creates a systemic diagnostic blind spot. It leaves hundreds of millions of patients entirely unprotected from massive residual cardiovascular risk. To understand why this biomarker is so hazardous, we have to look at its per-particle atherogenicity. Genetic data confirms that a single LPA particle drives approximately 6 times more vascular damage than a standard LDL particle. This 3D model shows the foundational structure of the particle. It begins with a cholesterol-rich core wrapped by a single molecule of apolipoprotein B100, which is the primary structural protein found in standard LDL. The defining feature of LPA is the covalent attachment of a specialized glycoprotein known as apolipoprotein A. It locks directly onto the ApoB 100 molecule via a single, rigid disulfide bridge. This ApoA tail is built from a series of 3-dimensional loops called Kringles. Specifically, the Kringle 4 type 2 domain features extreme copy number variation, meaning genetics dictate whether a patient has as few as 2 or more than 40 of these repeating loops. There is a strict inverse relationship at play. If you inherit fewer repeats, you produce a physically smaller protein isoform. The liver synthesizes and secretes these smaller isoforms with highly increased efficiency, which heavily spikes the circulating concentration of LPA in the blood. Between 70 and 90% of this structural variance is dictated entirely by the LPA gene locus on chromosome 6. Your baseline concentration is effectively fixed from birth. Because this lethal concentration is hardwired into your genetic architecture, traditional lifestyle interventions, including strict diets and intense endurance exercise, are structurally incapable of altering your risk profile. The physical structure of LPLA translates directly to 3 severe vascular pathologies. The first hazard is that it acts as the primary plasma carrier for oxidized phospholipids, generating intense localized inflammation. As we see here, these oxidized lipids act as distress signals inside the arterial wall. They recruit circulating immune cells called monocytes, which engorge themselves on the trapped lipoproteins to become foam cells, physically building the necrotic core of a plaque. This local oxidative stress causes endothelial nitric oxide synthase, or eNOS, to short-circuit. Instead of producing protective nitric oxide, the uncoupled enzyme produces destructive superoxide radicals that actively induce cell death in the vessel lining. The second hazard is mechanical. This diagram shows a standard blood clot composed of a fibrin mesh. Under normal conditions, plasminogen molecules bind to the structure and dissolve the clot. However, the looping ApoA tail of our particle is structurally nearly identical to plasminogen. LPA competitively wedges into those exact binding sites on the fibrin matrix, actively blocking the body's natural clot-dissolving mechanism. The third hazard targets the heart's physical hardware. Elevated LPA is currently the only recognized monogenetic risk factor for calcific aortic valve stenosis. The oxidized lipid cargo carried by the particle directly induces the expression of bone morphogenetic protein 2. This chemical signal forces the interstitial cells inside the aortic valve to undergo osteoclastic differentiation, literally turning the valve tissue into bone. LPNA represents a systemic triple threat. It independently accelerates plaque necrosis, inhibits breakdown of lethal blood clots, and structurally calcifies heart valves. If the medical community has known about this particle for 60 years, why haven't broad lipid-lowering drugs stopped it? This chart, built on Mendelian randomization data, maps the answer. Mendelian randomization is an analytical method that uses natural genetic variation to determine causal relationships between biomarkers and diseases. The data establishes a strict mathematical threshold. Achieving a clinically meaningful 20% reduction in coronary risk requires a massive absolute drop of roughly 100 milligrams per deciliter of LPNA. The core metric for clinical benefit is the absolute mass of the reduction. Proportional percentage drops are irrelevant if they do not cross this specific threshold line. Take the historical use of niacin, which lowers LPA by up to 30%. For a patient starting with a moderate baseline of 50 milligrams per deciliter, a 30% cut only removes 15 milligrams. It falls drastically short of the mandatory 100 milligram threshold. This tiny absolute drop mathematically explains the failure of massive outcome trials like AIM-HIGH and HPS-2 Thrive. Niacin simply could not clear enough physical mass, a failure further compounded by its high toxicity profile. This absolute mass requirement also explains why modern PCSK9 inhibitors, which also lower LPA by roughly 30%, only show significant coronary benefits in patients who start with exceptionally high baseline levels. If your starting concentration is astronomical, a 30% reduction finally translates into enough absolute mass removed to physically lower your coronary risk. For decades, judging clinical trials by relative percentages masked a clinical oversight. Repurposed drugs failed because they simply could not clear the sheer physical volume of Lp(a) required to achieve vascular safety. Because hitting that absolute benefit threshold requires an 80 to 95% reduction for most high-risk patients, the field is abandoning repurposed lipid medications. The new approach is dominated by targeted therapeutics, specifically antisense oligonucleotides, or ASOs, like pelacarsen, and small interfering RNAs, like olpasiran. These therapies bypass the circulating blood entirely. As visualized here, they target the hepatic cells in the liver, intercepting and degrading the transcribed messenger RNA before the ApoA protein can even be assembled. phase 2 clinical data confirms the efficacy of these RNA-based therapies, demonstrating sustained, dose-dependent LPA reductions of up to 95%. This massive level of suppression easily clears the absolute mass reduction threshold required to mimic the protective effects mapped out in the Mendelian genetic models. By shifting the strategy from clearing circulating lipids out of the bloodstream to halting protein synthesis at the genetic level, RNA interference provides a mechanism capable of neutralizing the LPA threat. In parallel, the therapeutic landscape is expanding with the development of muvalaplin, the first targeted oral medication for lowering LPA. This diagram illustrates muvalaplin's distinct structural mechanism. It acts as a physical barrier, disrupting the initial non-covalent bond and preventing the ApoB and ApoA components from successfully assembling into a lethal particle. The definitive proof for this new class of therapies will arrive soon. Massive phase 3 cardiovascular outcomes data from the Horizon and Ocean trials are expected to read out in 2026. Until these targeted treatments are fully approved, the immediate directive for medical practitioners is clear. Implementing the universal screening of Lp(a) at least once in every adult's lifetime is non-negotiable. Evaluating health based solely on standard LDL targets misses a massive variable. Identifying elevated Lp(a) is the mandatory first step in addressing a patient's true residual risk.